Good evening, everybody. Thank you for joining us tonight. I hope everybody can hear and see. It's a great pleasure to introduce Mervyn. Part of our previous discussion should have been, in fact, included in this introduction, because you have to realize that, that in the last few years, Mervyn and I have been occupying the same building at UCLH. We've been in the same place, and it's been one of the great pleasures of that to be able to talk to him and communicate with him and to hear about what he's doing. And the one thing he left out from his CV is that, of course, he's an absolutely superb communicator.
Thank you.
And it's going to be, and I look forward to hearing about this, because, of course, it will also show us what a remarkable innovator he has been under quite remarkable circumstances. Mervyn.
Oh, thank you. That's very sweet of you, David. Thank you very much indeed for the invitation, and thank you for those who have tuned in to listen. Let me go on to screen share, and hopefully the technology will work. Right, so please tell me, David, does that...
That's fine, that's perfect.
Lovely. Okay, so with apologies to Sting and police, I'll talk to you about a little device I helped develop as part of the COVID crisis. And what I'd like to do is tell you a story. And this is a story about having a focus on a precise goal. It's very much a race against time because the crisis was upon us. It's a paean to teamwork, and I think that will hopefully shine through in this talk. And obviously we needed a fair bit of luck, hoping to find some gold with our efforts. I think it's fair to say, I do intensive care clinically, and I think it's fair to say that COVID's a horrible disease, and the likes of which we'd not seen before. And we were getting these pictures from China early on of these rapidly developing horrific chest x-rays. The virus in particular targeted the lung. You got this very nasty inflammatory response, thrombotic response, and as a result, many patients suffered quite profound hypoxemia. And in fact, more than 15% of patients requiring hospital admission needed more than just face mask oxygen to support them. They needed admission to critical care for other support. The trouble was that this sudden rush of critically ill patients overwhelmed the critical care resource in both China in January and Italy, mainly in the Milan, Lombardy region in February. And essentially they ran out not just of critical care beds, but of mechanical ventilators. And this is just a little timeline. The first 100 confirmed cases appeared in China on the 20th of January, Italy about the 23rd of February, and the UK around the 5th, 6th of March. And so we did actually have a few weeks to learn from China and from the Italian experience. I think it's fair to say that the UK was rather slow to react. And I don't think we took on board adequately the lessons from China and Italy, who had been caught largely unprepared. Just to play you a little bit, no doubt many of you will remember Yes, Minister.
In stage one, we say nothing is going to happen.
Stage two, we say something may be going to happen, but we should do nothing about it.
In stage three, we say that maybe we should do something about it, but there's nothing we can do.
Stage four, we say maybe there was something we could have done, but it's too late now.
So I think that's very much a case of art imitating life 40 years later. And I think the penny dropped, or at least the government opened out to the public on the 13th of March with Boris pronouncing to the nation that, yes, many lives will be lost. And then we started having the sort of horror headlines The virus may put 8 million into NHS hospitals. The most frail may not get critical care because of a deficiency of critical care beds. And in fact, unfortunately, because of under-resourcing the NHS over many decades, we lag behind many other developed countries in the number of critical care beds per 100,000. So you see we're about half that of Italy and France, and way behind Germany and the United States. So in total in the UK, we only have about 3,500 beds, and by using anaesthetic machines that aren't really fit for purpose, but they serve some purpose, and ventilators borrowed from the private sector, we could just about over double the capacity. But the modelling suggested we'd need up to 40,000 ventilators. However, the whole world was looking for ventilators, and the United States in particular were very good at gazumping everybody else. So there was a worldwide shortage, and we're not only short of beds, but there's also a lack of staff. So suddenly to scale up from 3,500 to 40,000 ventilators would put an overwhelming burden on the limited number of staff trained to look after mechanical ventilation.
Houston, we have a problem.
Yes, indeed, we have a problem. And as you can see from the picture, and perhaps I can superimpose our beloved Prime Minister, you know, how did he and his advisors respond? And essentially, he came up with this dramatic plan to get British industry to sort of mimic the pre-war effort and build lots of Spitfires. But in this case, it would be Rolls-Royce and Dyson and so forth building NHS ventilators. We'd need 30,000 more. However, in my humble view, this was totally misguided. It's not easy to develop from scratch, especially with companies who aren't healthcare companies, to make ventilators that are sophisticated enough to cope with ventilating these patients' bad lungs. And clearly the message we were getting from China and Italy was that these patients were not easy to ventilate. And so to make them in weeks, let alone months, to my mind was an impossible ask. And as I mentioned before, there weren't this number of trained staff to cope with a large influx of ventilated patients. And this was, my views were shared. This is from the Financial Times a month later. And basically the penny had dropped by then that basically the clinicians and the regulators said these devices that the manufacturers were coming up with weren't fit for purpose. Around the same time, we were getting the horror stories from Italy, where the hospitals were overcrowded. And you'll see this picture from the Daily Mail, and you can see that what they're taking a photograph of are patients having CPAP, continuous positive airways pressure. And what do I mean by that? Well, this is something we're familiar with in clinical practice. It's a non-invasive means of respiratory support that is used as a halfway house between an oxygen mask and full ventilation. And it works by generating a high flow of oxygen air mix under pressure, and that positive pressure splints the lungs open, and it helps redistribute the ventilation and perfusion within the lung, thereby improving oxygenation. So just a very quick schema. The patient wears a tight-fitting mask or similar, and you put this air-oxygen mix at high flow, and the patient breathes out through the tight-fitting mask through an expiratory valve, what's called a PEEP valve. So you don't breathe out, exhale to atmospheric pressure. There's a certain degree of positive pressure, 5-10 centimeters of water, and that keeps the lungs splinted open. And you may be familiar with sleep apnea, and patients often wear these at night around their nose, but the more sophisticated machines need either a tight-fitting mask over the mouth and nose, a full face mask, or placed over the whole head, a helmet or a hood, as I showed you in the Italian picture just before. However, because of a fear that using high-flow devices like CPAP, high-flow nasal oxygen, nebulizers, would generate an aerosol which would potentially increase the risk of transmission of the virus to healthcare workers, the World Health Organization, many national guidelines basically didn't recommend the use of such devices. And this is the first advice from the NHS, 16th of March. And you can see that there, avoid high-flow nasal oxygen and use CPAP, non-invasive ventilation, confined to short periods only as a bridge to invasive ventilation. So these weren't recommended by the NHS. So that was the 16th of March. However, doctors in China and Italy had already turned to CPAP, high-flow nasal oxygen, to save the limited ventilator resource in the ICU beds for the most needy. I showed you that thing from the 16th of March. I'd been emailing lots of colleagues in China and in Italy as to what was going on from their perspective. And this is just one email I got from a colleague who's quite high up in China. He's the troubleshooter sent out by Beijing to deal with any big disaster in China, an earthquake, a train crash, whatever. And he was sent to coordinate the critical care response in Wuhan. And he said that, you know, non-invasive ventilation, high-flow nasal cannula are everywhere. Yes, they may have a high failure rate. If you wait too long in the patient struggling, that may not help the patient. However, he continued, you'll probably understand that with the surge of hundreds of patients with severe hypoxemia, many with very low saturations, even with oxygen, you just don't have enough resource for invasive mechanical ventilation. And the Italians were saying the same. On the right, this is a flow chart from the Ligurian region. And you can see here that CPAP actually features high up in their algorithm, their treatment algorithm. And a friend of mine who was one of the leaders of the Lombardy Regional Emergency Response Team, I spoke to him and he said, look, I haven't got any hard data, but I'm absolutely sure CPAP is the answer. You need to keep people off ventilators. And I wrote round to a dozen different intensivists I knew around Italy, and their experience was similar. About anywhere from 30 to 70% of patients could be kept off ventilators. They hadn't seen any of their doctors, their nurses looking after these patients, ending up as critically ill themselves. And yes, they were wearing PPE, but there were big shortages, not only in China, but in Italy. And as I'll talk about later, CPAP is oxygen hungry, but they weren't commenting on any problems with oxygen supply to their hospitals. So at UCH, I fed back this information that I'd gleaned from my colleagues in China and Italy, and basically we all bought into the concept that this seemed sensible. And obviously there were lots of discussions with intensive care, respiratory medicine, the hospital management were brilliant, and they basically fully supported us going against the then NHS guideline. And so we prepared from the beginning to try and introduce CPAP, to try and reserve intensive care beds and ventilators for those with the most need. And so we developed a clinical management algorithm, which commenced at the emergency department. The respiratory team in particular took on a very large training program for doctors and nurses so that CPAP could be used in a cohorted ward area to try and keep the intensive care beds free for those in most need. We only, unfortunately, had 12 standalone CPAP devices in the whole trust. We tried to get some more, but there was a worldwide shortage and none were unfortunately available. So we launched, this is our algorithm that we launched on the 20th of March. And this is beginning in the emergency department. Patients would get an oxygen challenge, and depending on how they responded to that oxygen, their respiratory rate, their saturations, and so forth, they'd go into different pathways, red, amber, yellow. If they weren't coping on oxygen alone, they'd try CPAP. If they weren't coping on CPAP, and if they were appropriate for intubation and ventilation, they would be intubated. The day before, that's when COVID really hit London big time. And you may remember Northwick Park got inundated with patients, and essentially they ran out of ventilators and critical care beds and had to declare a major incident. So now let me just shift to our CPAP journey. So as I mentioned, that I'd begun hearing what had been going on in China and Italy from early March. And after the ventilator challenge was announced by Boris Johnson, UCL, our engineering department, was asked if they could help with coordinating these consortia of non-healthcare companies like Rolls-Royce, Airbus, and so forth to make ventilators. And Becky Shipley, I'll show you a picture of her in the next slide, she knew me and she rang me, and I said, no, we don't want ventilators, we want something else. And we met on the evening of March the 17th, a Tuesday evening, in the senior common room at UCL over a drink, and I met with a colleague, with Becky Shipley, who's the Professor of Healthcare Engineering, and Tim Baker, who's the Professor of Mechanical Engineering, and basically impressed upon them that we didn't want ventilators, we wanted to keep people off ventilators, and we wanted CPAP devices. Having a few grey hairs, I'd remembered that we used to use, before fancy machines with bells and whistles and alarms and monitors came in, a very simple mechanical device called the whisper flow. And it had actually been invented in the UK in 1992, a small company in Sussex. That company had been bought out by Respironics, who had been bought out by Philips. However, you know, these work very well. They'd just been superseded by more fancy, sophisticated devices. And we found out subsequently that they went out of patent a few months prior. They were very simple to operate, just 3 knobs, an on-off knob, a knob to change the oxygen concentration, a knob to change the flow. And that was it. It plugged into the oxygen supply. And I thought, well, it's an old device. It's easy to get regulatory approval. It would be much simpler to make than a sophisticated device. But the question was, how quickly could it be made at scale and during a global lockdown where clearly the world's economies were shutting down and factories were closing? Luckily, Tim Baker, in a previous life, used to work in the motor racing industry, and he had very good connections. And so he actually had trained the guy who's now the chief engineer at Mercedes High Performance Powertrains. They're the people who make the engines for the Formula One teams, not just Mercedes. And the machines, the engines rather, are actually made in Northamptonshire, in Brixworth, and they have 800 people machining the tools there. And right down there at the front, you'll see the guy on the right is somebody called Lewis Hamilton, you've probably heard of, and the guy next to him is the managing director, who's also an engineer by training, called Andy Cowell, and he's, as you'll see later, a very good engineer. So they were rung up that evening. Andy Cowell immediately agreed to join the team, come on board, and the following morning he dispatched his 4 chief engineers to work at UCL alongside our engineers, and in the meantime they also sourced a whisper flow device. We'd found one in our anaesthetic department museum, and he found one on eBay for £50. And they essentially took it to bits, CT scanned it, did component analysis to see what materials were being used, all very clever, very fancy stuff, using the technology to design, build Formula One machines, engines, to look at this CPAP device. And you can see here, this is, you know, they had all these beautiful drawings and all very clever 3D reconstructions. And they set about starting to make parts. So in their factory, they've got lots of machine tools, and they cut out the parts, the blocks, and machine them and put them all together. And hey presto, you have a CPAP device. And in 4 days, they delivered the first prototype to UCH so we could test it out. So in 100 hours, they went from the original to a replica, an exact replica, right down to the same metals used for each part. And that's me on the 22nd, the Sunday evening, holding prototype 001 with Tim in the background. And as any good innovator wants to do, he wants to try it on him or herself. So there's me trying it out. And that's Andy Cowell. So this is in the room, just the physics lab, just off the intensive care unit. And he was sort of playing with flows and the device too. I'd also at this point like to acknowledge 2 other people who also make up the team. Dave Brearley, who's also an intensive care consultant at UCH, who worked very closely with me and the team, doing a lot of the clinical evaluations and stuff that you'll hear about later, and lots of clever ideas to boot. And the other guy is David Lomas. So David, apart from being a respiratory physician, is the Vice Provost of Health at UCL. So obviously he understood the need for CPAP, being a respiratory physician, and he bought very much into it and was hugely important in getting to the movers and shakers and in high ups in government, Department of Health and so forth. In fact, David made the first contact with the Cabinet Office and the MHRA, the regulatory authority, on the 19th of March. And it's fair to say we weren't necessarily welcomed with open arms. You know, Boris had wanted ventilators, and us coming along saying we wanted CPAP that was against NHS guidance didn't go down particularly well. So we had to persist, we had to try and persuade, and luckily we found some champions within the Cabinet Office and the Department of Health and the MHRA. So we had to be persuasive, we had to charm, influence, etc. And, you know, it was very much a hearts and minds exercise. And thankfully, it worked. So by the 24th of March, the NHS agreed for us to make 100 prototype devices. So we got our first income. So until then, it had purely been bankrolled by UCL and by Mercedes without any guarantee of funding. At the same time, clinicians were beginning to use CPAP in the UK, and people were saying, this is silly, the NHS guidance, it needs to be changed. And so on the 26th of March, version 2 guidance, they now said that CPAP is the preferred form of non-invasive ventilatory support. Its use does not replace invasive mechanical ventilation, but it may provide an important bridge and keep people off ventilators. And like in China, like in Italy, in the UK, we didn't see healthcare workers looking after these patients coming down with serious respiratory failure themselves. This is from the Intensive Care Society and the Faculty of Intensive Care Medicine in the UK on the 28th of March. And they acknowledged too, this went out to all the intensivists in the country, acknowledging that there is a growing evidence base for the use of CPAP in COVID patients. However, it's now clearer that CPAP may be of benefits to patients earlier on in the disease process and may prevent deterioration such that they won't need invasive ventilation. And yes, some people will need to go on a ventilator if they're too ill. However, the NICE guidelines have been updated to include the use of CPAP. So we convinced clinicians, the majority of clinicians, that there was a role for CPAP and it would be safe to use. And that was on the 28th of March. I mentioned in the meantime, we'd been talking to the MHRA, and this lovely guy, Neil Maguire, who in a former life used to be an intensivist anaesthetist in the Oxford Reading area. We contacted him on the 20th of March. He was obviously very happy to help. And we submitted our file for regulatory approval on the 25th of March, and he was as good as his word. 36 hours later, so from the Wednesday evening when we submitted a very large dossier with all the manufacturing details, the technical specifications, our volunteer data, literally they turned it round in 36 hours and gave us special authorization to use the CPAP during the COVID crisis. And condition was that before we send it out to lots of hospitals, we do some trialing at UCH and a few sister hospitals who had agreed to evaluate it. And so we began that on the 29th of March. At the same time, our communications department got into full stride at UCL. And again, with actually great assistance from the BBC, it went global. So Fergus Walsh put out a on the night of the Sunday the 29th on the BBC website, and then me and the team, we appeared on BBC Breakfast and subsequently many other programmes the following morning. I'll just play a little clip.
It delivers oxygen to the lungs without the need for a ventilator. Here's our medical correspondent, Fergus Walsh.
It's a small device that could make a big difference. Known as continuous positive airway pressure, or CPAP, it pushes oxygen into the lungs, keeping them open, making it easier to breathe. They're already used in the NHS, but are in short supply. So a team modified and improved an existing design in less than a week, which has now been approved for use by health regulators.
So, as I mentioned, it went global. It was a good news story, and also it was quite glamorous. You know, hospitals, academics working with a Mercedes Formula One team. And so obviously that got lots of interest from here, there, and everywhere. And there, you know, the ultimate accolades from Gary Lineker and Lewis Hamilton. Can we ask for anything more? Obviously, we got the regulatory approval and we were asked to make 10,000 devices in double quick time, because then London in particular was at the height of the pandemic crisis. And we were, you know, speaking as an intensivist, hugely overladen in the London area with very, very, very sick patients. A problem, though, that had been recognised was, I called it here, national hypoxia. British hospitals weren't designed to cope with many patients requiring lots of oxygen, and that was in danger of compromising the oxygen supply to the whole hospital. And in fact, the Royal Free at the end of March and Watford Hospital at the beginning of April had acute problems with their oxygen supply. The problem about CPAP, it is oxygen hungry, especially if the patient's needing very high oxygen concentrations and having to be delivered at very high flow rates. So to give you a comparison, if you're breathing oxygen by a face mask, 80% oxygen uses about 15 litres per minute. A mechanical ventilator is about 12 litres per minute. High flow nasal oxygen is somewhere between 40 to 60 litres per minute. And these high flow CPAP devices, not the home sleep apnea machines, but the ones we can use for sicker patients, go up to 140 litres per minute. So that's too high a consumption. And we knew this. We found off the internet the Whisper Flow manual. This is from 2006. And you can see 100% oxygen at high flow rates used a hell of a lot of oxygen. So we were aware from the very beginning that we had to try and make it more efficient. This is a picture of a diagram of the circuit. So you plug the device into the wall supply of the oxygen that's by every bed space. I should add at this point, we named it UCL Ventura. Why was it called Ventura? Well, the reason was I mentioned all these engineers basically came down from Mercedes and the UCL engineers, and essentially they stayed in a hotel for up to 4 to 5 weeks following working on this. And they didn't have time to go home and get clean clothes. So they had a fund to buy clothes and food and stuff. And somebody was sent out to get lots of pajamas. And he went to Marks and Spencer's before that got locked down. And the image was of Ventura Beach in California on the pajamas. And so that's how the device got called the Ventura. As you can see, there's a disposable circuit that leads from the device to the patient. So there are filters that go in at the beginning and end. But I'll come back to that in 1 second. The Mercedes people had identified that they could do fairly easy tweaks which would improve the efficiency of flow within the device. However, they'd also noted, the engineers at UCL and Mercedes, that there were large pressure drops across different components of the patient circuits, across the viral bacterial filter, the hosing, the tubing that goes to the patient, the filter that's on the expiratory limb to stop virus being spewed out to the nurses and doctors, the mask and the PEEP valve. And many of the commercially available masks and tubes and filters were essentially not fit for purpose. There were very large pressure drops across these components, which meant for the patient to breathe comfortably, you had to have very high flow rates. So they set about testing and improving on all of these components. And that they did. And you can see there the Mark II device with the tweaks basically achieved, with the improvements to the patient circuits, efficiencies of up to 70%. So this is a huge reduction in oxygen use. And that Mark II device was approved a week later on the 2nd of April. Again, the MHRA did us proud. Going back to that diagram, I'll also mention the oxygen analyzer, because clearly you need to know how much oxygen you're delivering to the patient. But worldwide shortage of them, we could only source a small number from overseas. There were, I think we got the only 5 remaining in the UK, and some were sent from China via Singapore, via Switzerland to the UK. So there were a shortage. So we needed to get more machines built in double quick time. I'd been doing research for many years with a small company outside Oxford. It has about 20 employees, and they make very good oxygen monitoring equipment for cells and for tissues. And I rang up the boss and said, hey, we need your help. We need an oxygen analyzer in double quick time. And so from scratch, they designed and built it, tested it, and they got regulatory approval. And this is what they built. And that got MHRA approval 3 days later on the 5th of April. So again, we were up and running. Mercedes started making them. I mentioned they've got 800 people in their factory, and so they started making them at bulk. I think the most they made in a single day was over 1,200 devices. And we started delivering them to the NHS on the 11th of April, and they finished their 10,000 order on the 15th of April. So less than a month after the first idea, we got 10,000 devices delivered to the NHS. The problem we then encountered was distributing it in the NHS. I'm sure you'll remember there were all these problems with supply chains, delivering PPE and other things. There were shortages of drugs, other equipment, etc. And in fact, the army had been called in to help, and we spoke to a high up in the army, and he said, basically, if you can do it yourself, that would be much better. And again, another company came to help. And this is a company who make parts and distribute parts for the automotive industry for Formula One. And they operate what's called a just-in-time logistics service. So I know when you go to a garage and the garage needs to get a spare part, they don't have a huge stock. They ring, and basically within an hour or two, a van delivers the part to them. That's what's called a just-in-time service. And this company were brilliant. They set up a warehouse in Gloucestershire. All the parts went to them, all the disposable circuits, the devices, the oxygen analyzers. They set up a clean lab that was MHRA approved. They packed them all in a clean, sterile manner, and then NHS hospitals could call them off, and they had a website where they could call off devices and parts. Has it made a difference? Well, it's hard to say. We haven't done randomized controlled trials, but you know, I think certainly the view that putting everybody on a mechanical ventilator may not be such a good idea. And this is again in the Financial Times in mid-April, and this is also towards the end of April. We were managing to keep about half of the sickest patients off ventilators, either managing them with CPAP on the intensive care units or on respiratory wards to spare the intensive care resource. And the government decided all of these ventilators that they'd asked for, all these consortia, they basically said thanks, but no thanks. Basically, there wasn't the need, and also I think the clinical view was they weren't sophisticated enough to do what we actually wanted, you know, for these complex patients. I'll play this video. This is of one of the first patients we did, and Fergus Walsh came to the intensive care unit. So he was the first journalist allowed in an intensive care unit, and he filmed this guy on the CPAP device. And this is a film done a few weeks later. And there's the patient with it on.
I would have thought you're probably still feeling a little bit a bit weak.
Well, I'm feeling quite good at the moment. Daytime, my life is like as if it's normal. But I get over there by relaxing myself and breathe.
Thank you, we got him home. All thanks to you.
Yeah, so which is a nice story, and it helped him. And in fact, we've supplied over 60 hospitals in the UK, and including the Isle of Man and Montserrat and so forth. The other thing we felt it was very important to do is not to just keep it local, but to try and help the rest of the world, in particular countries who are poorer. And so on the 8th of May, we released open source designs, and a whole host of actually companies, some universities started making them. Mexico, Peru, Uruguay, Philippines, Australia, Canada, etc. And we were supporting that initiative. Also, some charities have bought devices, and they're now being used in Uganda, South Africa, and so forth. Again, we were doing this, there's no profit to be made, and so we were very clear that we wanted this humanitarian gesture to be carried on by companies who could make these devices around the world. And so on a website, there was the availability to download all the design, the manufacturing package, how the tooling, the specifications, educational videos, teaching aids, etc., so that different countries can set up in their own country if they couldn't afford to get them themselves. And many countries, as I mentioned, are doing so. We had over 1,800 requests that were downloaded from 105 different countries. So it showed that there was a worldwide need for these sorts of devices. I'd like to finish just with about 4 or 5 slides and just sort of reflections. And then please, if you've got any questions of me, I'll be delighted to try and answer them. I think it's fair to say we rode our luck. We were gambling. They were calculated gambles, often blind. They had to be taken on trust. we had to believe that we were right in our perceived clinical need and that this need would gain traction in the UK and adoption by both clinicians and obviously healthcare administrators. It took a considerable degree of courage by UCL and Mercedes to sign off a lot of money with no guarantee whatsoever that any of this money would be reimbursed. And I think the Dean of Engineering at UCL made £250,000 available as initial seed funding, which I think was an amazing gesture. We had to be confident that, yes, we could produce devices rapidly and at scale. Clearly, you know, getting hold of the components, getting the oxygen analyzers, getting all the consumables for the patient circuits. We all had these challenges to overcome. And obviously the devices had to be safe. It would be awful if something went wrong and a patient suffered as a consequence. We were aware right from the beginning about potential issues with oxygen supply. So, you know, we were very reliant on the assurance of the engineers and their confidence that they could re-engineer the original device to make it much more oxygen efficient. And, you know, we had this conviction that we could not only help the UK, but countries outside the UK. I think it taught me a lot about teamwork. I think it was crucial to be agile and to be part of a multidisciplinary team. We had clinicians who said, this is what we want, this is our shopping list. And we worked hand in hand really closely with engineers in the environment. At UCL, they've got this beautiful space for mechanical engineering, and at the Mercedes factory that allow these things to be developed, improved upon, manufactured, tested at pace. And we had this lovely interaction between academics and industry, innovating and translating. And besides us, we had this brilliant project team who helped coordinate, communicate, and we had multiple people we had to liaise with: component manufacturers, distributors, government bodies, lawyers, regulators, the media, etc., etc. You know, lots and lots of things had to happen simultaneously. So teamwork was of the essence. Human factors also, I think, really, really important. We didn't really know each other as a group. I knew Becky Shipley, but I didn't know anyone else apart from David Briley and David Lomas. So we all had to gel quickly together, and no particular ego had to sort of dominate. We all had to work closely as a team, communicate, listen, and adapt. We had to be persistent, we had to be resilient, we had to have a fair degree of chutzpah, I think. You know, this combination, we had to be professional and credible, to be charming, to be pushy, and we needed to collect the data, the clinical data and so forth, to convince clinicians, healthcare leaders, regulators, suppliers, because there was a demand for parts, and we had to say, hey, we need the parts too to build our devices and consumables. And so they had to be convinced of the clinical utility and the deliverability. It was important to maintain focus, that we didn't want to deviate, we didn't want to over-engineer the product, we wanted to get it out, adapt and modify it as quickly as we could. And therefore we needed to trust each other, our capabilities, our judgments, and work closely together. And to believe that what we were doing would hopefully contribute to the COVID crisis. Lessons learned. It's interesting working with these people, from Mercedes, from G-Tech, the logistics company. I was gobsmacked at how quickly they innovated, designed, manufactured. There were clear lines of command and control. The logistic delivery was just phenomenal. And, it just, I think, put the NHS to shame, basically. And it just showed me, taught me how these sort of combinations, these partnerships between industry, academia, healthcare, regulatory partnerships, need to be efficient and streamlined and synergistic to break down barriers to innovation and adopt novel, effective technologies at pace. There is a threat, there will be, unfortunately, a very severe economic recession, and the universities, I think, will be struggling. Healthcare will be struggling. And I think one thing we've learned from this crisis is over the last few decades, the UK manufacturing base has shrunk. And so we need to make sure that we can be in the future much more self-sufficient. The other thing which I think is disappointing is that the developed countries looked after number one, Britain included. So we placed trade embargoes on drugs and devices we made in this country to the detriment of countries that couldn't afford to manufacture drugs and devices. And I think, we're part of a one planet, and I think there needs to be much more collective responsibility for global health. My final or penultimate slide, I'd just like to acknowledge lots of people. We're proud and delighted to have done this within a month, and a huge host of individuals, the university, hospitals, companies, governmental bodies who gave so generously and so rapidly their time, their resource, their expertise, and not for profit, freely. It was all done magnanimously. And these people rose to the occasion. They worked very long hours. There was this wonderful can-do attitude, and there was lots of respect, good humor, and focus. And it was hugely impressive how many of the usual bureaucratic barriers could be largely dismantled within the university. Decisions could be made at pace. Within the hospital, decisions could be made at pace by, government funders, et cetera, et cetera, et cetera. And basically the idea of delivering a device that could hopefully do some good. So I'll finish there. Thank you very much indeed for listening, and I'll hand you back to David.
Thanks, Mervyn. And am I unmuted? Can you hear me?
I can hear you.
Excellent. Okay. Thank you very much. That was a fascinating journey through a remarkably short space of time. I was, kind of remind, the famous, what the Jules Verne, around the world in 100 days, around the COVID-19 respiratory attack in 30 days virtually. A couple of immediate questions. One obviously coming from Leon, not only to say that it's a brilliant talk, but also to ask the question about what about patient outcomes? What do we know about patient outcomes? Did anybody die on this device? How many people had to go on to ventilators?
No, sure. So essentially the UK experience mirrored what I was hearing from China and Italy. So approximately half the number of patients who went on the device could be kept off a ventilator, which obviously is good for them because the average time on a ventilator for these patients is about 2 weeks. And so therefore the turnover of patients who needed mechanical ventilation was very slow. So about half. And the other thing I think it also offered, and certainly I know in the town cities where we were being overwhelmed, some people unfortunately, couldn't go or weren't, it wasn't perhaps, appropriate for them to be ventilated because of frailty, more comorbidities and so forth. And so we could offer to many of these patients CPAP as a ceiling of care, so more than an oxygen mask. And again, the UCH figures about, I think it was something like in total 75% of patients who had CPAP survived, and 24% of those patients, and these were patients who were for full everything. So some people of those 75% needed to be intubated, but in total about 3/4 survived. Of those who were having a ceiling of care of CPAP, about 1 in 4 survived. So at least we were able to offer something more to these patients rather than just an oxygen mask.
Right, and that raises the other question. But it wasn't known at the time during that period that you started off, but what about the relationship to the drugs, dexamethasone and remdesivir? Were these being given to any of these people at the same time?
No, remdesivir was essentially didn't really get much daylight in the UK. We weren't one of the trial centres. And in fact, when you look at the New England paper, remdesivir only helped people at an early stage. So by the time they got to intensive care, there was no outcome benefit. And so it shortened the degree of illness early on. But once they were in my hands, unfortunately, remdesivir doesn't seem to offer much benefit. In terms of steroids, I'm a steroid fan, and so it was quite nice to see dexamethasone in the recovery trial coming up positive, and the benefit there was actually seen at the sicker end of the spectrum. I think we're all a bit surprised at the huge treatment effect from a low dose of dexamethasone, because it's certainly not been shown before in other types of acute respiratory distress syndrome or viral pneumonias. And I think there are lots of questions about the trial and the results, but you know, I think there is a positive signal, so clearly that's something to be applauded.
And there's a difficult question from Simon Cohen, inevitably also, which is, apart from this particular innovation and this particular, development, from an intensive care point of view, are there other improvements in intensive care that you think have arisen as a result of the COVID-19 experience?
Thank you, Simon. I think actually communication. I think we try, and Simon well knows that, communication is very, very important. We were in this horrible situation where relatives were banned from the hospital, and they still are, unfortunately. And it was devastating for patients where you have these critically ill, loved ones, and they couldn't communicate, and they were very, very reliant on us communicating with them. And so we had a brilliant communications team. In fact, our oral surgeons, the dental surgeons, ran a superb service of providing relatives with information, to spare the intensive care clinicians time to actually look after the patients, because we were hugely busy with clinical work. Obviously, we talked to relatives if there was, the sort of matter of life or death situations. And what we would also do is allow one family member to come in if their loved one was critically ill or sadly dying. But I think one thing we did very well was to try and really boost the communication side of things. And we brought in iPads, and so that the relatives could see their loved ones in the bed, and when hopefully the patient got better, and they could communicate. So it was good for the family to see the improvement, and also good for the patient that they could communicate with their loved ones at home.
Do you advocate or did you advocate the use of antibiotics at the same time? John Newman raised that.
I'm an antibiotic nihilist. So I think what happened was, a lot of the time they just come in with straightforward viral pneumonitis. Later on, and about 50% of patients on ventilators could get a secondary nosocomial bacterial infection. And we were actually, we're trialing, there's a sort of point of care. So Dave Brearley, who I mentioned in my talk, so he's trialing a point of care respiratory panel. So in just over an hour, you can get, I think it's 15 bacterial and 9 viral targets and some resistance genes as well. And so it was quite useful to pick up at very short notice detection of bugs.
Right, and I suppose I'm entitled to come in at the point of when you refer to David Brearley as to where he learned some of that. But,
Indeed.
But the question is, were you measuring things like antibodies, and is that going to be carrying on for these people? Are they going to get antibodies? Are they going to?
Good question. There are, again, lots of smallish trials. A colleague of mine in Italy wrote me that they've given IVIG, intravenous immunoglobulin, with, it's not a randomized trial, but with some seeming benefit. Clearly, you know, there are trials in the US and the UK of convalescent plasma. So I think, you know, we'll wait and see. Hopefully they'll do something. Hopefully a vaccine may come along. You know, there's clearly lots of, you know, I don't claim any virological expertise of note, but clearly, you know, just because you've got antibodies doesn't necessarily give you immunity. And many people, again, some of my colleagues who got COVID, were positive for the viral PCR, are actually now antibody negative. So how long lasting the antibodies will be, even if they offer protection, we don't know, unfortunately.
The questions always start to come in and get more difficult as they go along. But what do you think of the New England paper on microvascular coagulation as being the factor in the lung?
Yeah, no, absolutely. I think one of the things we saw, which was far more prevalent than any other condition, was a huge degree of thromboses. So we were not only seeing deep vein thromboses, arterial thromboses, but a lot of pulmonary emboli. And on post-mortem examinations, there was a lot of microvascular thrombi in the lungs in particular, far more than you see with standard ARDS. And so, again, the Italians and then in the UK, we shifted relatively early from just a standard low-dose anticoagulation approach to a bigger dose. And clearly in those people who had got overt DVTs, PEs, they had full anticoagulation. So I think there certainly is a major role in the pathology of this condition with a marked prothrombotic tendency.
And Ian Goodman asked about the question of communication, the communication between people wearing full PPE. How does that work in the?
Yeah, it was painful. I see his comment about, did you use Bluetooth? No, unfortunately, PPE is incredibly uncomfortable, and the level we were wearing in intensive care. So you had the gowns, you had aprons over the top, you had double gloves, you had a cap on, a hat on, you had the visor, you had a tight-fitting FFP3 mask, and so it was hot, sweaty. The elastic from the mask cut into your face or ear, and you couldn't hear anything. And so you were having to shout to be heard, and vice versa. People talking to you had to be shout to be heard. You know, we had walkie-talkies brought in to help, you know, communicate from outside the cubicle or the bays to the people outside. But it was difficult. It was difficult. I've heard of some people trying to develop better means of communication, but it was certainly not pleasant. Right.
The one question, well, penultimate question is Alan Sam. I said, what's the next thing you're going to invent?
Thanks, Alan. Well, it's interesting. Our engineers have certainly got the flavour for it. So at the moment, in fact, it's just got MHRA marked rather. But do you remember I showed those pictures of Italian hoods that unfortunately are only made in Italy, and Italy placed an embargo on hoods leaving Italy because they needed them for themselves. And so we hardly had any. I think we only had about 6 or 8 in the whole of UCH. And so we're actually now making them. And so our engineer is actually making them, and we think it's actually better than the Italian one that's out there. And we're making it one of these biological weapons, well, not weapons companies, but companies that protect you against biological warfare. It's a company called Avon. And so they've been helping with the development, and we've been trialing that at UCH. And so that's the latest tick box we've added. And there are a few other devices to try and optimize the flow that we're also developing. The royal we, it's the engineers with the clinicians giving hopefully useful feedback and input.
And do you think we're ready for the second wave?
Good question. We'll be better, much better prepared than for the first wave. I think there was a lot of fear and paranoia at the beginning. It was very much a step into the unknown. There was the worry about safety for the staff. So I think we'll be better organised. I think the hospitals I mentioned in my talk, the UK was caught on the hop, and we weren't prepared in terms of testing, track and tracing, PPE, ventilators. So I think next time round it will be better. My fear is if it does blow up, if it blows up in the winter, you know, when there's a whole load of other viruses also, you know, there may be a bad flu season as well, then things might get potentially sticky.
Do you have any theory? Did you have a lot of Jews in your?
Actually, great question. The ones we had were mainly Hasidic Jews.
Right.
So we had a disproportionate number of people from Stamford Hill and Golders Green. Now, is it because they were more susceptible for whatever reason, you know, like BAME communities are, whether it's vitamin D deficiency, whether the lack of social isolation? Because I think if I remember rightly, Purim was just at the beginning, and there was a lot of partying, and people weren't socially isolating. So whether or not, you know, there were social factors contributing, but we did certainly have a disproportionate number of Hasidic Jews.
I think that we've got one final question, which is really, Glenda Baum says it's actually a comment, not a question. So I'm going to read this one out, because I think it's a good point to say thank you. This whole story is absolutely amazing. 10,000 CPAPs distributed in the first batch in a week. Also amazing is the efficiency of the government and official systems that seem in most other COVID aspects to have got this very wrong. This was not a job for the boys, but a philanthropic project, which can only have happened because of the excellent communication. And this is full marks to the boss, and that seems to have been you and your close colleagues. Story could be made into a film in future years. Well done, and thank you.
Thank you very much indeed.
That's a good point to end on.
Can I just say, we laughingly joked about this. So we gave ourselves, which actor would we like to play us? And I bagged George Clooney.
Well, good luck.
In my dreams.
And you know, a lot of medical students really became medical students because of George Clooney's appearance in, I think, in Casualty.
ER, yeah, indeed.
ER, sorry. Thank you very much. And just to say good night to everybody, thank you for joining. And next week, we have another speaker also from a different angle of UCLH. We've got Dr. Mike Grossman, who's looked after child and adolescent psychiatry, and who was looking after child and adolescent psychiatry issues during the same period. So look forward to seeing you next week at the same time. And thank you once again.
Thank you. Bye-bye. Bye, everyone.